Thank you, everyone, for being here and for your attention this afternoon. Thank you, Dr. Treppel, for that introduction. So just taking a step back for a moment, we've now seen a lot of wounds, a lot of how to treat those wounds, infections. So taking a step back and trying to prevent these wounds from forming. Okay, so let's meet our surgical candidates. I'll briefly go over 3 current patients. 1 has been operated on, 2 have not. So I'd welcome kind of any feedback. Feel free to poke me and share with me any insights you all might have. So our first case example, first patient, this is our healthy 26-year-old female. We'll see shortly why I have healthy in quotes. But her chief complaint is a recurrent left subsecond metatarsal head painful hyperkeratotic lesion. It has been present for over 2 years, and looking at these clinical photos, we can see that subsecond metatarsal callus there, and looking at just the structural deformities of her foot, doesn't have a bunion, but does have a few hammer toes there. So we think to ourselves, is this really all attributed just to that hammer toe? So looking at that hammer toe mechanism of action, if you will, that rigid contracture at that proximal interphalangeal joint is causing that hyperextension of the metatarsal phalangeal joint. That constant downward pressure combined with that repetitive friction and pressure has caused this callus to form. So now that we saw the clinical, looking at the radiographic standpoint as well, we see that there's a slightly longer second metatarsal, which is important to consider, and that muscle and tendon imbalance. Is that something that we would also have to address? So you asked the patient a few more questions. Again, she's healthy, 26 years old. What's your medical history? Didn't really have any medications, maybe on some vitamin D supplementation. Any surgeries? Yes, she had surgery to her left leg. She didn't really lead with this at the start of the visit. But this is what her left lower extremity looks like. And that's only from the knee down. But she's had significant trauma history. And again, she didn't lead with this. It took a little bit of probing to actually get this out of her, oddly enough. So she suffered a motor vehicle accident in 2017. A pole impaled the left lower extremity. Needless to say, she had significant osseous trauma, neurovascular trauma, that tib-fib fracture. It was complicated by osteomyelitis. She did require multiple INDs, hardware removal. As if that wasn't enough, she's been through a lot. In 2023, she was riding a horse. She happened to be off the horse when this happened, but the horse tripped and fell, and she fractured her femur. So looking at the radiographic standpoint of this, this is what, I'm not intervening on, but this is what we have to work with. So from that overall biomechanical standpoint, something, you don't want to ignore either. But like I said, she didn't lead with this, and she wasn't actually symptomatic to the rest of her left lower extremity. It was just this callus that she had. So as I mentioned, she did have significant trauma, and as part of my workup, I always get an ultrasound ABI on the patients, and you would say, oh, she's 26 years old, not significant medical history, she had some trauma. Do you really need the ultrasound ABI? Not thinking much of it. I've gotten these studies on other similar demographic patients, and they have no vascular disease. But this patient did have significant vascular disease. And when I got these results back, I was a little bit surprised. Again, unfortunately, she didn't disclose a lot of this to me, even with some probing, with a TBI value of 0.56 and an ABI value of 0.69. So I've referenced here just kind of these values that we look at. So again, highlighted in yellow, that moderate PAD 0.4 to 0.9 ABI, and then a TBI value of less than 0.70. And here are her values again. So she's well below those thresholds. And when I shared this with her, she was like, oh, of course, I only have 1 vessel to the foot. Would have been nice to know, maybe could lead with that next time. But nevertheless, thankfully, something we uncovered before the fact, not after the fact. So once I saw this, kind of your index of suspicion of things going wrong is certainly higher. And then just, again, kind of going through that vascular workup, it did reveal that the anterior tibial and posterior tibial arteries had been ligated, so that was dating back to the 2017 trauma she had. And even the perineal artery did show some occlusion as well. So with this portion of the workup at this point, we were really hoping that she had established strong collateral flow, which was mentioned at one of our earlier talks. So even if she was, a candidate, it unfortunately couldn't have been direct. It probably would have been an indirect approach, but thankfully they didn't feel that she was a good fit for any intervention, at least at this point. So vascular recommended that we go ahead and get TcPO2 values, or TCOMs, those transcutaneous oxygen measurements. So just something to keep in mind when you have patients with that vascular disease, kind of going one more step further. So her TcPO2 values were adequate. They were well above that 50 threshold. So vascular team said, go ahead, do surgery. So we did that surgery, and again, this is just kind of those reference values that the average for the first and second toes in a transcutaneous oxygen measurement should be above 50 for healing. So looking at what our surgical options are. So again, we had that recurrent subsecond metatarsal callus. So the options that I was really looking at are doing the metatarsal osteotomy. I didn't feel that just addressing the hammer toe that was addressed, but I didn't think that would be enough. I really wanted to give her that plantar offloading. So you could do the wall osteotomy, the dorsiflexory wedge osteotomy, which I've annotated with the asterisk, that's what I ended up doing, or a distal metatarsal diaphyseal osteotomy, which I'll just kind of anecdotally refer to as that floating osteotomy, that transverse osteotomy. And then not to forget, there are other instances, because this patient is young, active, had 2 toddlers. You could argue for other patients that have that plantar forefoot overloading, possibly a metatarsal head resection, but I just wanted to keep it maybe more conservative, if you will, in terms of surgical intervention. So these are intraoperative films. I ended up fusing across the DIPJ and the PIPJ of both digits. My thought behind that was, because she is 26 years old, I wanted to give her really the most definitive correction, especially considering all the trauma that she had to the left lower extremity. I think when she gets older, she is maybe going to suffer maybe more biomechanical deficits because of that. So I locked up those joints to avoid kind of the crisscross crazy toes, when she's 56. And then I fixated that that dorsal metatarsal osteotomy with 1 screw there. So this was the last time I saw her, in July, so just a few months ago. No callus, no pain as of now. So that was kind of A to Z for that example. So the second example, so what do? This patient has not had surgery yet, and you'll see why. Similar complaint, recurrent left subsecond metatarsal head callus, but she's neuropathic, no pain. A little bit of a blessing and a curse there, but her A1C is 10.2. So again, because these patients have not gone to ulcerate yet, this would still be in that realm of that elective surgery. So, we're kind of working them up to make sure they're optimized as best as possible. She is insulin dependent. She has lowered it. This A1C used to be at a 12, so we're doing better, but slowly but surely. But again, similar complaint. So how can we address this for her? But you can see from the clinical photos, she does have that bunion as well. She has the hammer toe, and again, that subsecond metatarsal callus. Here are her x-rays. So that severe bunion, an IM angle of 20.9 degrees, almost 21 there. And then, again, getting that ultrasound ABI value. So they are reporting no evidence of arterio-occlusive disease in this patient based on her TBI of 0.76, looking at that threshold of wanting it to be above 0.70, but they're not reporting her ABI because her vessels are non-compressible. So then you have to argue, is this the best patient to still do elective surgery on? From a results standpoint, they're not saying that she has PAD, but I would then refer this patient for ongoing vascular workup, because this diabetic vessel wall calcification could pose an issue in the future. So then the question is, again, do we do the whole shebang, kind of address everything, do the bunion, do the hammer toe, do the second metatarsal osteotomy, or do we just, seemingly address kind of the root cause of at least that subsecond metatarsal callus, if you will? And especially being neuropathic, the bunion isn't necessarily bothering her, even though we know that, maybe from kind of a domino standpoint, the bunion set everything off, made the toe get contracted, forced the metatarsal phalangeal joint to be hyperextended. So I've listed out here, kind of what I would say in completion, addressing the bunion as well. Or do you just do that second metatarsal osteotomy and possibly even a second digit amputation? Because the way this is contracted right now, from a functional standpoint, she's not really loading this digit. And she's at increased risk of developing a corn or a callus to the dorsal surface of that digit as well. So that's another opportunity for a wound. So yes, we want to address that subsecond met ulceration, but we possibly, want to save her from developing a digital wound as well. And here's that last case example. So she doesn't have that subsecond metatarsal callus, but subfirst, she does have that hallux valgus deformity as well. This patient is maybe what I would say a healthy 75-year-old. The last patient was in her 50s, but relatively, non-healthy, especially just from kind of a lab standpoint. So in terms of history, this patient, obstructive sleep apnea, controlled schizophrenia, and high cholesterol with an A1C of 5.5. And I think at one point she was pre-diabetic, but looking at the 5.5, not even pre-diabetic in category. So she's more of that healthy older patient. Adequate vitamin D, she's been supplementing well, but something to consider is she has a hallux varus on the other side. So she's been through the gamut with surgery before, and that's what she wants to avoid. And on the other side, she happened to have fusion of the first met cuneiform joint. So in the back of her mind, that's what she's thinking in terms of recovery. So we spoke to this patient, addressing the bunion, addressing the hammer toe. But, based on her hesitation with the contralateral foot, you could argue, do you also just do an amputation here and try to offload that subsecond met? Because she's 75, doesn't want to be off her foot again, even though she had the contralateral foot done many years prior, and maybe she was able to withstand the recovery, but now at 75, she's not willing to do that. And here are her corresponding radiographs. Her ultrasound ABI, she does not demonstrate any evidence of PAD, so again, kind of that healthy older patient, if you will, with an ABI of 1.19 and a TBI of 0.71. So just going a little bit deeper into what the literature tells us about these surgical options I've presented for the second metatarsal specifically. So the one I did on that first case example was that dorsal closing wedge osteotomy. The reason I chose this in particular was because I didn't want to have a great degree of shortening. Looking at the wall osteotomy, we can get on average about 3 millimeters of shortening, but with doing the dorsal closing wedge osteotomy, you don't get the same amount of shortening, but you are able to resect that wedge of bone and essentially dorsiflex the head of the metatarsal to reduce that pressure. So metatarsal head is allowed to migrate proximally and dorsally, still in the sagittal plane, so this isn't giving you that frontal or transverse plane correction, so it really is just sagittal. But for that case example 1, that was really just my intention to try to offload that peak plantar pressure to the second met. So looking at this study here, published in JATMA in 2016, they did a combination of the wall and the dorsal closing wedge osteotomy. So yes, you can do these procedures in isolation, but you could also pair them, as they did in the wall group in Chicago. So their method, behind doing this was to get that shortening and also to elevate that metatarsal head. And overall, they showed that by 24 months, so it was a good long post-op, if you will, almost 2 years, the mean VAS score decreased, the AOFAS score, patient satisfaction increased, and they were able to retain that range of motion. So this could have been a suitable proposition as well, especially when you have that young, healthy patient that has otherwise, their full mobility. So now shifting gears onto that floating osteotomy, this is looking at the foot and ankle international study. This was specifically minimally invasive. So I think especially kind of in that older demographic of patient, maybe that 75-year-old where you don't want to make large incisions, or in the diabetic patient with a very high A1C, this minimally invasive option, smaller incision, less soft tissue destruction, and they found that it was an effective method in promoting diabetic foot ulcer healing, regardless of the grade severity. So I think if you're able to offer this to a patient maybe preemptively before they go on to develop a strong ulceration, then this study definitely supported the effect of that. Looking at this next study in lower extremity wounds, so this was a retrospective chart review, small subset of patients, 54, 71 osteotomies, again, that minimally invasive approach with a Shannon burr. Interesting here, they were looking at the radiographic findings specifically. 10 had non-union, but these were asymptomatic. So the goal was achieved if you're looking at ulcer healing and offloading specifically, but you can see from this example x-ray, it's not maybe the prettiest or most aesthetic x-ray, especially if you're looking of more of that atrophic non-union, kind of that whittling of the bone end, if you will. 15 patients had hypertrophic callus formation. One of those patients ended up having to undergo another surgery to resect that painful callus. And then 62% had normal union. So, a little bit more than a flip of the coin, had the normal union, normal healing of those bone ends, if you will. But then you kind of have to ask yourself, would I rather have the patients with the non-union that don't have that hypertrophic callus, or have the one patient that has to go back and maybe is going to develop another ulceration because of that? So again, maybe not the prettiest x-ray, but when you're looking at the goal of achieving, ulcer healing, then I would say, goal achieved. And then just the last thing to kind of leave you with, because we are kind of in the elective surgery realm, what is a safe A1C to move forward with when discussing elective surgery? So sometimes you have a very narrow window of time. You see a patient 4 weeks later, they've already gone on to ulcerate. So it's a very narrow window of time you're looking for. An A1C, there's a greater window, usually a 3-month average, but the threshold that most of us refer to is that 7.5%, as anything above that can significantly increase the risk of a surgical site infection. So 7.5 is the benchmark I necessarily go with as well. But we can see from the Journal of Investigative Dermatology, they were looking at ulcers specifically. So these patients had already gone on to ulcerate, and they showed that the larger baseline ulcers in the patients with the lower A1C went on to heal better than the patients that started out with a smaller ulcer but a higher A1C. So there was that kind of opposite relationship, but it was really all tying back to A1C control. And then they were able to quantify for every 1% increase in A1C, the daily healing rate decreased by 0.28 square centimeters. So, you might not be able to measure kind of square centimeters, on a clinical case by case, but we do know that as that A1C increases, your healing rate will decrease. And then lastly, just to kind of show that, this following, and we hope that our patients have endocrinology follow-up, because we might not be able to follow their diabetes care as closely or adjust their medications, that the relationship between A1C and healing can be very complex. But some studies are showing now that if you're able to achieve A1C control in the perioperative period, so essentially, probably less than the 3-month workup it takes to work up one of these patients, if you're able to achieve control then, perhaps they did have an A1C of 12 in the past, but if they're able to bring that down and maintain that, then you have better likelihood that they will go on to heal. So just in summary, strongly consider including the ultrasound ABI as part of your preoperative workup, even in healthy patients. As I said, I was a little bit surprised myself. And patients, they might not be thinking about it or think that it necessarily relates to what you're going to do. So just make sure you always do a deep dive and be thorough with that. Don't forget the rest of the body. Even if there's clear foot pathology, biomechanics in the rest of the body can play a role, even if it's something that could have been attributed to trauma. Different strokes for different folks. So each patient might require a different surgical approach. That just happened to be mine for that first case example. But there's many ways to kind of slice and dice a hammer toe, if you will, or different bones in the foot. And there's not always a direct linear correlation between A1C and healing, but the perioperative control is the most important. So I think, we don't want to be dismissive of patients that have had that A1C, especially if we offer them the opportunity not to ulcerate in the future. So thank you so much for your time.